Okay, today I'll talk about posterior cruciate ligament, PCL. Anatomy first, it originates from the lateral border of the medial femoral condyle, and it inserts to the posterior tibia in between both of the tibia plateau, medial and lateral tibia plateau. So function, it restricts the posterior translation of the tibia in relation to the femur, and then it helps in secondary restraint of external rotation, and also help in protecting the extended knee from valgus and varus stress. Mechanism of injury for PCL, usually patient presented with trauma during a knee flex and plantar flex of the foot, and then usually blow to the anterior knee and or blow to the anterior tibia, and also during hyperextension or hyperflexion of the knee. Next is the clinical presentation. Usually patients present with a mild to moderate swelling, and then they complain of pain over the posterior side of the knee. For flexion wise, they will complain of a loss of a terminal knee flexion, and occasionally instability if there is a multiple ligament involvement. Next one, we'll go into physical examination. So first, inspection. Look for any ecchymosis, any swelling, and then any abnormal in the patient's gait, antalgic gait. And then look for any deformity. For example, genu recurvatum or bow leg in those who have chronic PCL tear. And then important to look for step off, and then for palpation, look for other ligamentous injury also and then for special test for PCL is a posterior drawer test, and then look for any posterior sagging and the quadricep active test. So PCL injury can be classified into 3 grades: grade 1, grade 2, and grade 3. Grade 1 and grade 2 is a partial tear, and then grade 3 is a full tear. So grade 1 is when there is a tibia translation in relation to femur, translating back for 0 to 5 mm. And then grade 2 is when the translation is 5 to 10 mm, when there's a flush and the anterior tibia is flush with the femoral condyle. And then grade 3 is when the translation more than 10 mm, indicating a complete tear. So for imaging, can do a plain radiograph to rule out any fracture, avulsion fracture, and also to look for posterior tibiofemoral subluxation. And then the gold standard for PCL will be MRI for diagnostic purposes. And then for the treatment part, for acute treatment, usually we'll still go with the RICE treatment So rest, compression, elevation, and then also medication for analgesic. And then later on, once we get a proper diagnosis of PCL injury, patient can be either go for operative or non-operative treatment. So for non-operative treatment, usually it confines to grade 1 and grade 2 injury, and modalities will be usually with quadricep rehab, focusing on the strengthening. Subsequently and also for relative immobilization for the early stage of injury, put on the expansion brace with a limited ROM. And then when we decide for ops, the indication is when there is a combined PCL injury with other ligamentous injury, or whenever there's any avulsion fracture, or when patient complain of instability, patient complain functional unstable knee. So for op, for those who going for op, post-op, we like to immobilize the knee in extension and protect them against gravity. So for early mobilization, suggested in a prone position, early motion in prone lah. And also focus on quads rehab post-op. Also, we do not allow any resistant hamstring strengthening exercise during the early phase post-op. So that's all for PCL.